So maybe a couple of minutes more so that everybody gets a chance to join in.
Is Varun going first?
Sure. All right, let's, good evening. I think we're going to get started with today's grand rounds. And today we are going to have a recap of our important trial highlights during the American College of Cardiology annual scientific session that happened last week, April 2 to 4. We had a good meeting with a good presentation, sets of presentation. Overall, we had 27 presentations, which is almost doubling up from the previous years. So I would like to congratulate the division, the fellows, faculty, mentors, and everyone who has contributed. And we want to continue this trend. ACC is one of the most respected meetings. And what we decided to do is to dedicate the next 2 grand rounds for finding out what was important and what was well liked in the meetings, which allows the fellows and the faculty to pick up topics of their choices. And it also allows us to understand how we can be better informed with the modern developments. Today, we have 3 speakers. We're going to have Dr. Varun Bhasin. Dr. Bhasin is a second-year fellow in cardiology. And he did his residency from Stony Brook University Hospital. And previous to that, his education was from Virginia Commonwealth University School of Medicine. Varun has a great interest in research, and he's an astute clinician. And he's been very prolific, at least in the first year, trying to work with us on several research projects. Today, he's going to provide us a compendium of different clinical trials. With that, Varun, please go ahead and take away the presentations.
Thank you for the introduction, Dr. Sengupta. So today, I'm going to highlight one trial, the Impulse trial. This is a really intriguing trial from ACC this meeting. And it's a fresh trial that was recently published in Circulation on April 4th. So I found this quite interesting. So Impulse, the effects of empagliflozin, symptoms, physical limitations, and quality of life in patients hospitalized for acute heart failure. So I'm going to start with some background here. So SGLT2 inhibitors, as we know, have emerged as an excellent therapeutic option for patients with heart failure. It's already been shown to improve outcomes and rates of heart failure, hospitalization in ambulatory patients with heart failure. These trials, I'm going to just set the stage. These trials set the stage for the Impulse trial, including the EMPA-REG outcomes trial, which demonstrated that empagliflozin resulted in a lower rate of all-cause mortality in patients with type 2 diabetes who are at risk for cardiovascular events. Subsequently, the EMPA-REDUCE trial looked at patients with an EF less than 40% and demonstrated a lower risk of cardiovascular death or hospitalization for heart failure in these patients in the presence of or absence of diabetes. Additionally, EMPEROR-Preserved in patients with an EF greater than or equal to 40% also demonstrated a reduced combined risk of cardiovascular death or hospitalization for heart failure. So these trials were quite compelling. However, very few therapies have actually been shown to improve symptoms and functional status in patients in the early post-discharge period and patients hospitalized with acute decompensated heart failure. So the impact of SGLT2 inhibitors in acute heart failure has been largely unknown, and that's where the Impulse trial comes in. So for the study objectives for the Impulse trial, it investigated the effects of empagliflozin on symptoms, physical limitations, quality of life, and in patients with decompensated heart failure. And the impact was examined based on a broad range of health status outcomes as measured by the Kansas City Cardiomyopathy Questionnaire over time. So I'm just going to highlight some of the inclusion criteria here. They included patients admitted to the hospital with decompensated heart failure regardless of ejection fraction or diabetes status. So patients with reduced DF or preserved DF, and diabetics and non-diabetics. Those with blood pressures, systolic blood pressures greater than or equal to 100 and no hypotension, and patients who did not have any increasing in their IV diuretic doses or IV vasodilators within 6 hours, no inotropes within 24 hours. And patients had NT-proBNP greater than or equal to 1600 or BNP greater than or equal to 400 during their hospitalization. The IMPULSE trial excluded patients with cardiogenic shock, PE, CVA, and acute MI as the primary trigger for the hospitalization. Also, patients with LVADs or on inotropes or those who are undergoing heart transplant eval were excluded. Additionally, patients on dialysis or those with severely reduced GFR, less than 20, were excluded. So I'm going to take a moment here to highlight and explain the study design. So it was a double-blinded randomized controlled trial of about 530 patients. The mean age was 71 years, and 33% of participants were female and 47% had diabetes. So data came from 118 centers across the world in Europe, North America, and Asia. And again, these were patients who were inpatient, hospitalized with acute decompensated heart failure, and they were stabilized. And then the median time from hospital admission to randomization was 3 days. And then they were randomized to the empagliflozin 10 milligram arm or the placebo arm. So each group had 265 patients, and the Kansas City cardiomyopathy questionnaire was utilized to assess these patients on days 1, 15, 30, and 90. So we saw them over time. So in regard to the Kansas City cardiomyopathy questionnaire, it's a tool that has been validated as a clinical outcome assessment and recommended as a performance measure for patients with heart failure. It can capture the impact of heart failure on patients' lives and quality of life, and is strongly associated with clinical events over time. So it's been independently validated, it's reproducible and interpretable. So it's a 23-item self-administered questionnaire that asks patients questions about symptoms, physical function, quality of life, and social function. And it's a reflection of the prior 2 weeks. So in this study, they did a 0 to 100 score in which higher scores reflect better health status. So this illustration from a JACC review just maps out how the Kansas City cardiomyopathy questionnaire really assesses things in regard to the disease progression associated with heart failure. So as you can see, disease and then symptoms, functional limitations, quality of life. And there are symptom scales, physical, social, and function scales, quality of life scales. And in regard to this, it has overall summary scale and a clinical summary scale. So there are different domains of this questionnaire that assess the patient through different steps in the disease progression. Now, in regard to the primary outcome, they looked at the total clinical benefit at 90 days. And this was a hierarchical composite of time to all-cause death, heart failure events, and a 5-point or greater difference change from baseline in the Kansas City cardiomyopathy questionnaire at 90 days. So on this slide, I'm just illustrating the way they presented clinical benefit at 90 days. They took a total symptom score for the Kansas City questionnaire, and they broke it up into 3 tertiles or 3 groups based on the score, with 27 being the lowest score and 52 being the highest score. And as you can see, they had a comparable number of patients in both groups and in each group here. So what they did is they used something called a win ratio, which is a method for reporting composite endpoints. And that's easy to use and gives priority to the more clinically important events such as mortality and rates of hospitalization. So essentially, it's a reflection of the odds that the patient in the experimental group did better than the patient in the control or placebo group. So they calculated significant win ratio and demonstrated that empagliflozin was better across all symptom scores, reflecting that there was an improvement with the medication, even despite varying symptom profiles at baseline. So now moving to our secondary outcomes in this trial, they looked at mortality, and mortality was 4.2% in the drug group versus 8.3% in the placebo group. Heart failure events were also less at 10.6% versus 14.7% in the placebo group. And there was also a lower rate of renal failure in the empagliflozin group, 7.7% versus 12.1%. And they also saw a significant body weight change in the empagliflozin group. So this next slide really illustrates the different domains of the Kansas City Cardiomyopathy Questionnaire, including the clinical summary score, physical limitation score, and quality of life score. And you see significant improvements in every domain, all four graphs, at 15 days, which persists and is maintained all the way to day 90. So this really illustrates that there is improvement with the drug and across all domains during the study period. So very compelling results. So now that brings me to the clinical implications. So these findings are really intriguing because there's so few therapies that have really been shown to really impact symptoms and functional status in early post-discharge periods after a hospitalization for decompensated heart failure. And again, these findings were consistent across multiple subgroups, and the benefits of empagliflozin were regardless of ejection fraction, regardless of the heart failure being de novo or chronic, and regardless of the degree of symptomatic impairment at baseline. So now I'm going to touch a bit on the limitations of this trial. There was a sizable group of patients of 530, but it's not one of the largest trials. And in regard to the follow-up period, it was limited to 90 days. So we don't see what happens to that benefit later on at let's say 120 days. And of course, the inclusion exclusion criteria can limit your generalizability as well. An important thing to note is also that the Kansas City Cardiomyopathy Questionnaire is a self-administered survey, and it's based on the patient's own perception of their health status. In this analysis, they use multiple imputations to account for any missing data. So of course, missing data is a limitation, but the proportion of patients with missing values was similar in both groups, and it was not skewed to one group. So in conclusion, empagliflozin in patients with acute heart failure was associated with a significant clinical benefit, improved symptom profile, physical limitations, and quality of life. And you see these benefits so early at 15 days and was maintained through 90 days. And again, independent of their baseline symptom profile. It was also associated with lower mortality rates and lower heart failure hospitalization rates, and a greater reduction in body weight. So to conclude, the one thing we think about as clinicians is the cost. That what is this going to cost our patients? It's beneficial, but what's going to be the barrier? So without insurance, Jardiance can be an expensive medication. 1 month supply can run you over $500. However, in patients with insurance, about 88% of patients pay about $0 to $45 a month. And then the remaining 12% pay an average of $203. So in insured patients, a vast majority of patients, this is actually something that can be quite affordable if they have insurance. And of course, in Medicare and Medicaid, small copays each month actually make this a relatively affordable medication. So, I'm very excited about some of this data, and it's going to be interesting to see how, this impacts our practice going forward. Okay, thank you.
Thank you very much, Varun. So a couple of questions. So there's one question that is coming up, and that's in the chat box, is that prior data suggests that in preserved ejection fraction CHF, these drugs helped symptoms but did not change mortality, was this subgroup with preserved ejection fraction separated out? Or in other words, I think the question is whether the signal was same for both preserved and reduced ejection fraction.
Yeah, from what I understand is that basically was the mortality the same in heart failure, preserved ejection fraction, the reduction in mortality, correct?
Yeah, well, so prior analysis did not have a reduction in mortality for preserved ejection fraction. Was a separate analysis performed here?
So as far as I know, this included both reduced ejection fraction and preserved ejection fraction. So regardless of the ejection fraction, there was a mortality benefit, and that included patients with preserved EF here. I don't think they separated it out and specifically looked at preserved ejection fraction separately, but that's an interesting thought.
So Varun, the second question that follows up, and that may be more interesting to ask is, heart failure is pretty heterogeneous, and particularly heart failure preserved ejection fraction is very heterogeneous. You have several studies that have shown that there are different phenotypes within so-called heart failure preserved ejection fraction, where there are cardiac and extra cardiac factors that are responsible for the heart failure. So there's skeletal, there are endothelial dysfunction, so on and so forth. Where do you think does this pathophysiologically make an effect such that it doesn't matter that the heterogeneity of the heart failure and the pathophysiology of the heart failure does not matter, because it seems like it's the impact is all across the board?
So I've seen some data that indicates that, SGLT2 inhibitors, the mechanism there can be an osmotic diuretic effect. And that can, as you're seeing in this trial, there's weight loss happening, reductions in blood pressure, and improvement in quality of life. So that's one purported possibility for the mechanism of why we're seeing, SGLT2 inhibitors really making a difference in quality of life. In regard to the extracardiac manifestations, it's not really, I'm not really sure in regard to how SGLT2 inhibitors impact those manifestations. And I'm sure here in this trial, things are limited based on the questionnaire and the questions that were asked. And I think they mainly focused on cardiac related manifestations and heart failure symptoms. So I think that would definitely warrant for future study to understand how SGLT2 inhibitors affect, different systems and the extracardiac manifestations.
Yeah, and I remember a study that was done and published. This was an animal study, of course, from Mount Sinai that was published in JACC, which showed that the effect of the study was not just on the on the diuretic effect, on osmotic diuretic, but I think it at the cellular and interstitial level, they were able to demonstrate impact on fibrosis, anti-apoptotic mechanisms, and so on and so forth. So it may be more extensive and further needs to be figured out. But it is interesting. It is interesting to note that despite the heterogeneity, the drug is able to bring in the same amount of effect across the board. And of course, the heart failure preserved ejection fraction continues to be a very challenging subgroup, but the very fact that you do see response there, the only other drug that is known in some trials to have some impact is spironolactone. But previous to this, we didn't have much choices. So I think this is a welcome effect, and I think there's more ongoing studies that are going to be performed. So more to come. Any other questions before we will move on to the next presentation? Please feel free to put it in the chat box, and I can read out and moderate it for all of you. Thank you. Thank you very much, Varun. And our next presenter.
My pleasure.
Yes, thank you very much. So if you would uncheck your slide. Yes, so the next presenter is Dr. Abel Moreyra. Dr. Moreyra, everybody knows him, and he's a clinician, educator, been with us for a very long time. He's professor of medicine. He's been the director of the cath lab till about 2014. He has been the acting chief of cardiology before Dr. Karamelas came, and he has probably trained the largest number of physicians in this area. And I was briefly going through his CV and his extensive contribution to research in the cath lab and cardiology in general is reflected in the lot of publications and a lot of the educational and research contributions he has had and the impact he has had on the division over the years. So thank you, Dr. Moreyra, for your services, but also most importantly, despite his legendary status here, he continues to be prolific. So his work was selected as a spotlight and featured. So we invited him to give us more insights into his recent work. Dr. Moreyra?
Okay.
I'm hoping that you can, so can you bring off the spotlight, Joseph? Very good.
Can you see the screen now?
Yes, we are good.
Okay. Thank you, Dr. Sangutta, for the very kind introduction. I'm going to present the abstract that we presented in the meeting of the ACC last week. So the title of the abstract was "The Impact of Exposure to Transportation Noise on the Rates of Myocardial Infarction in New Jersey." How can I advance that slide? So it might look strange for the audience to see this slide. This is a rock band, and that, believe it or not, this slide has something to do with the presentation. This gentleman that you see in green here is my nephew, and he was playing. Like many of us, he had a midlife crisis, and he decided to go back and play guitar in a rock band. One night he was playing, he had chest pain, cold sweat. He was called the ambulance, taken to a hospital. He had an acute ST elevation MI, got angioplasty, and everything goes well. By the way, this person here, I think Fady was asking me whether it was me. No, I had nothing to do with the rock band. So this is just, I don't know who this person is. So being the only physician in the family, of course, the family started asking me whether the noise of a rock band while he was playing had anything to do with MI. And my answer was no. To my knowledge, noise has nothing to do with MI. To me, MI is due to a rupture of the plaque, and to my knowledge, noise doesn't rupture any plaque. That was my answer about 4 or 5 years ago. Probably the thing stayed in the back of my mind, and one day I was reading a magazine and I read that in Frankfurt, the airport, one of the most important airports in Germany, around Frankfurt, it was curious to see that the number of strokes around the airport, in the area around the airport, was higher than the rate of the strokes was higher than in the rest of Germany. So coming home, I said, well, what about infarctions in New Jersey? New Jersey has many highways, it has airports. So I went to Dr. Costis with this idea, and I thought he was going to tell me that I was crazy. But no, he told me, it's interesting, and the same as the epidemiologists that were working with him. So the idea took off. Like in many things, some things were easy, like to have the number of infarctions in New Jersey because we have a good database, the MIDAS database. The question was how to get noise in New Jersey. And so I contacted the Department of Transportation in the US, and to my surprise, the Department of Transportation has a good record of noise in the country. As you can see, the Midwest and part of the West are quite pleasant, little noise, whereas the East Coast is plenty of noise. The next slide. So now this zooms into New Jersey, and you see the state of New Jersey quite heavy in noise. The northern part with the airport, 2 airports around Philadelphia, around Atlantic City, and the same happened for New York. And this other slide shows even better what the noise situation is around where we live. The blue color is a very high noise. And as you can see, that this blue color coincides with runways of airports. This is Newport, this is the airport in Northern Jersey. I never remember the name of that airport. This is Kennedy, this is LaGuardia. So as you can see, people living in these areas are exposed to high noise. At least I was not much aware of the level of noise that we are exposed in our daily life. And this shows you more or less what kind of decibels we are exposed. For example, rain has 50 decibels, a conversation 60, a truck running on the highway is 90, a rock band, which applies to the beginning of this idea, is 110 decibels, very close to the noise of an aircraft taken off from the airport. So this is more or less what we are exposed in our daily life. So this originated, this abstract, that this is the poster that was presented, and for some reason got a lot of attention. And I'm going to go through the different sections. So what is the background? The background is transportation noise is a major environmental hazard affecting health. In the US, data relating exposure to transportation noise and cardiovascular disease is very sparse. There's very little data for the US. And this has been mentioned in circulation already, and I'm not here to this, that a new vision of preventing cardiovascular disease should now include not just the traditional risk factors. It should include an ecological perspective, incorporated environmental factors. So we investigated the incidence of acute MI in relation to noise in New Jersey. The primary objective of the study was to examine the association between exposure to transportation noise, that is noise from aircraft, railroad, and highways, and acute myocardial infarction. As I said before, we used the MIDAS database. That is the repository database that concentrates in all cardiovascular events in the state. We studied, this number is somewhat wrong, is more like 16 2,000 patients in the year 2018. Why 2018 is because the Department of Transportation collected noise data only for the years 2015 and 2018. It doesn't happen every year, which is, it is a problem for us for future studies. We use geospatial coding to convert subjects' residence to latitude and longitude coordinates and association with noise levels. We derived the counts of males and females with the mice in each municipality in New Jersey. Then we derived the population for each municipality for males and females. And the noise exposure for each municipality was assigned according to the data from the Bureau of Transportation. So the associations between noise levels of 60 decibels or more versus 50 or less, and the MI hospitalizations were estimated before and after adjustment for confounders, the confounders that we could found. And the association was expressed as unadjusted and confounded adjusted odds ratios derived from registered regression models. So this 16,000 patients, 16 plus patients were divided according to the noise exposure. There were 14,043 patients exposed to low noise levels, less than 50 decibels. There were 2,451 exposed to 50 to 60 decibels, and we call that high noise. And there were 164 patients exposed to very high noise, that is more than 60 decibels. The demographics of the patients with this kind of noise exposure is shown here. There's not much difference. Perhaps when we get older, we move to quiet place because less than 50 decibels, the average age was 68. Whereas for those in the very noisy areas, the average age of the mice was 63. Males were about the same. Black race was somewhat curious because more than 50 decibels exposure were fine. The proportion was about 25% and 17%, which is much more than black race exposed to the proportion of black race exposed to less than 50 decibels. Other races, that is mainly Hispanics, again, more than 50 decibels, the proportion was higher than the ones exposed to less than 50. And white race, as expected, there was a large proportion in the less than 50 decibels exposure. Comorbidities, curiously, hypertension and diabetes was not much difference in the three groups. Same for COPD. Atrial fibrillation was less in the very high noise group, although it was curious because there is one report associated atrial fibrillation to high noise. Renal disease was about the same, anemia a little bit less, and arrhythmias, that is excluding atrial fibrillation, were a little bit more higher than in the very high noise group, but also in the high noise group. Death, again, the death rate, these are hospital death, hospital mortality was higher in the patients exposed to more than 60 decibels, 5.4%, compared to the other groups that was about 1% less. This is the plot showing the myocardial infarction rates per 100,000 population according to decibels exposure. So the rates of myocardial infarction per 100,000 population in patients exposed to more than 60 decibels was 3,336. Whereas the rates of myocardial infarction for those exposed to less than 60 decibels was 1,938. Therefore, the ratio rates or relative risk was 1.72 with confidence intervals between 156 and 190. And this is highly significant. The population attributable risk for myocardial infarction to high noise was 5%. That means that 5% of the MIs in New Jersey were related to noise. This number is very much similar to the rates that have been reported in Europe. In conclusions, this population-based study indicates that exposure to high noise levels are associated with increased hospitalization rates for myocardial infarctions. 5% of all acute MIs hospitalizations were attributable to high noise levels, indicated the significance of noise exposure. The findings underscore the importance of stricter noise regulation and enforcement by the transportation authorities, and further work on the impact of myocardial infarction is needed. So what is the connection between noise or transportation noise and MIs? So the theory behind of the proposed pathophysiological mechanisms are shown here. These are plane, trains, trucks running the highways. This produced a disturbance in our activities, disturbance of our sleep, disturbance in communications. This in turn causes annoyance. Annoyance causes emotional stress, an emotional response. All this causes biological effects with increase in cortisol levels, angiotensin levels, dopamine levels, adrenaline levels, noradrenaline levels, changes in the autonomic system, causing inflammation, causing prothrombotic, activation of thrombotic pathways, and all this leads to endothelial dysfunction with a decreased vasodilatory response, with increased vasoconstrictions, with increased inflammation, and this in turn might cause cardiometabolic problems such as obesity. Obesity has been linked to noise, coronary disease, hypertension has been, the highest studies show that noise causes hypertension, arrhythmias, diabetes, and heart failure. So the last slide that I would like to show is this one, because that was what I showed before, is the so-called indirect pathway. The question is any direct pathway? And recently there has been a study from Zurich in Switzerland showing that myocardial infarctions, they occur at night. This is an area close to Zurich Airport. So they were able to track the landing and takeoff of airports at night, and death occurred at night, and the number of deaths within 2 hours of a plane takeoff or plane landing was increased compared to the other death that occurred at night. Therefore, this suggests that may also be a direct pathway between noise and myocardial infarction. I hope I didn't exceed the time. Thank you very much.
Thank you, Dr. Moreyra. I think that was a very excellent. So for our trainees, young trainees, I wanted to make sure that they were able to see a masterly act of how you form a hypothesis from simple observations or getting exposed to an idea, and then you take that idea, develop a clinical study around it, persist on it till you get the information, and then try to collect the information and correlate and develop a science around it. So this should be a great exercise. Thank you for doing that, Dr. Moreyra, because it's a great exercise for everyone to understand how do you start research and bring it to some form of a science and evidence development. I was very intrigued. So thank you for presenting that. But I have a few questions. And the number one was, and I was more interested in your hypothesis of how it is working. So I think it made sense that noise would lead to different types of neurological behavioral changes or annoyance and catecholamine stimulation, inflammation. I think I follow that. But let's say myocardial infarction typically is associated with clustering of chronic cardiovascular diseases, like you do see hypertension, obesity, smoking. I mean, you do see a clustering of metabolic issues. For some reason, I was very intrigued that when you provided the information about the underlying basic the risk factors, they were not different. So on one side, it is interesting that despite that them not being any differences in chronic cardiometabolic diseases, you do see an association with MI. On the other side, I also basically come back to your hypothesis, because wouldn't inflammatory pathways also lead to the same things like hypertension, diabetes, because they're kind of interlinked to each other. So did you have any comments about that?
No specific comments. It's very, you adjust for the confounders the best that you can, but I'm sure there are confounders that are around that I couldn't adjust.
Yeah.
But just that's like you mentioned, one confounder actually, the problem has been, I think now it's improving, is air pollution, because noise and air pollution go hand in hand. So how to separate but now because there is, but mainly in Europe, there is so much interest in this, that now there have been studies that were able to separate this confounder that was pollution. There are other things in my view. One is sometimes people don't live, sometimes they don't live, they don't work close to where they live. So maybe some people could be exposed to noise, but the record shows that his house is in the middle of the country and nothing happens. So all those things I think will be very, they are going to be hard, but if we put an effort, we might be able to clarify some of this point. But to me, looks interesting, this new aspect of not looking just at traditional risk factors.
Yeah.
To look at air pollution and to look at noise maybe also is playing a role. No, it's not a maybe, it's playing a role.
Yeah, and also one more thing I wanted to probably mention is that there are social determinants of health, and particularly places within this noisy surrounding. But I wonder what are the economic characteristics of the people who are staying, and whether there are other social determinants of health. And there is a clear science of what is called a zoning. Zoning in an urban environment has been associated with health outbreaks and health events. So this is very well understood. So there is probably a connection, not only just with perhaps what you presented, but also there could be other clustering of other unknown risk attributes, which it could include social determinants of health, economic strata of the society, which may be playing role because ultimately these are also risk factors. Dr. Altobelli mentions whether there is a legal liability for governmental agencies to looking to divert all the create new traffics or flight patterns. I think these are interesting challenges, and I think urbanization and zoning laws are in place. It's also interesting to when I was in West Virginia, this is not just the zoning laws, and you also create different types of food deserts and food pattern and eating and behavioral things. And it's very interesting that we do not think about the environment that contributes to the epigenetic machinery that leads to all this risk development. And the more we go into the environmental factors and its relationship to the metabolome and our genetic machinery, ultimately the chronic disease is therefore so complicated to see. Anyways, thank you very much. I think it's very intriguing. But what I loved in your presentation was your passion, your ability to take a research question, ask a hypothesis, and go for the information, and then bring it to fruition. So congratulations. It was a great demonstration of scholarly activity. Thank you very much.
Thank you, Doctor.
Now we go to our last presentation, and it's going to be presented by Dr. Rohan Shah. Dr. Rohan Shah is currently a research fellow at the Division of Cardiology, and he followed me from West Virginia University, where I had the ability to see him working as a resident. And his research has come to big fruition. And I was wanting to make an announcement that he's been selected as a Young Investigator Award finalist at the American Society of Echocardiography annual scientific session. So this will be perhaps, I don't know, first time in the history of Rutgers Robert Wood Johnson, perhaps in New Jersey. I don't know if anybody else from this part of the country has represented at the national championship. So congratulations. And Rohan has picked up a series of different research highlights from the ACC, and he's going to share with us. Rohan.
Thank you, Dr. Sengupta, for the kind words. Let me share my screen. Okay, hi, my name is Rohan Shah. I'm a cardiology research fellow here, and I'm just going to talk about a couple of interesting studies that I was able to attend to at this year's ACC conference. So I've been to a few, and they seem to be, they build upon each other every year. And this year, I think everybody had cabin fever and was really wanting to get out there and show new things. So after a 2-year virtual hiatus, there was a growth in topics covered and a really big focus on innovation. And some of these topics I saw were used to just be either posters or in the industry expo, but now have become actual panels. But I wanted to go through a couple of studies that really intrigued me. And I'll start with a rapid fire of prevention-oriented studies, either primary or secondary. So for lipid management, one of them was Pacman AMI, or vascular effects of alirocumab in acute MI patients. And this was a PCSK9 inhibitor started post-MI, immediately post-MI, status post-PCI versus statin. And the results showed a non-ischemic plaque or culprit vessel burden decrease. There's a decreased percent atheroma volume via IVUS, decreased maximum lipid core burden index, and an increased minimum fibrous cap thickness. And this showed early initiation provides a greater impact on PAC stabilization with PCSK9 inhibition. Then there was also the Apollo trial, which showed short interfering mRNA decreasing LPA levels by shutting down the LPA gene. And that is decreased LDL-C and ApoB by 20 to 30% at higher doses. Then there was a few interesting diet-based studies. There was a couple actually with coffee intake and CBD. This is a retrospective, there's 3 retrospective analyses from the UK Biobank by Kissler et al. And the findings included that without CBD, 2 to 3 cups of coffee daily had a 10 to 15% lower risk of CVD or mortality. And there was a U-shaped relationship between intake and new arrhythmias. And with CBD, 2 to 3 cups actually had a mortality benefit with no higher risk of arrhythmias, including AFib and flutter. And with arrhythmia at baseline, coffee was associated with the lower risk of death, including AFib, flutter, who drink 1 cup of coffee daily. Then there was sodium HF, which was a little bit interesting, as in the sense that this was usual care versus a sodium reduced diet of 1,500 milligrams daily. And the findings showed no effect of the salt reduced diet. However, you have to take into account that the baseline sodium intake in the usual care group was around 2,200. So not very indicative of possibly a typical US diet that typically exceeds 2,000. And then interestingly, there was a trial that actually showed that increased adherence to the DASH diet when using a grocery store-based nutritionist or a web app to deliver dietary guidance. Then in pregnancy, there was the CHAP study, chronic hypertension and pregnancy study, and that showed that aggressive blood pressure control improved preeclampsia and preterm delivery rates, as well as no difference in maternal mortality. This had 2,400 women, and the aggressive cohort had a blood pressure of less than 140/80. And the primary medications used were labetalol and nifedipine. And so for structural heart, there was a 5-year valve deterioration comparison between TAVI and SAVI. This was a joint comparison between the core valve US pivotal trial and the SIR-TAVI trials. And this is using core valve or Evolut. And the findings show that surgery has more structural valve deterioration versus TAVI after 5 years, and it's 4.38% versus 2.57% in TAVI. And having any structural valve deterioration, regardless of TAVI or SAVI, doubled your risk of hospitalization and mortality. And there's a risk of valve deterioration occurred most in those with larger VSA, women, younger patients, and healthier patients. However, the implications are far-reaching, as in this shows further evidence of TAVR durability in relation to surgery. And in the field of arrhythmia, the Partita study was extremly interesting. So this was studying the timing of VT ablation with patients with ICD. And the primary endpoint was all-cause mortality and heart failure hospitalization. So the first phase was an investigation of what predicts shock. So this included ischemic cardiomyopathy and non-ischemic dilated cardiomyopathy with ICDs for primary or secondary prevention of VT. This included 517 patients, 2-year follow-up with a uniform ICD programming that included long-term detection intervals of 20 seconds and extensive ATP session to prevent shock. The second phase was a randomization between immediate catheter ablation within 2 months, so very aggressive, or conventional therapy. 47 were randomized after the first shock. And the findings were a superiority of catheter ablation on the primary endpoint, mainly in the mortality benefit, and fewer subsequent shocks after ablation. And the number of ATP treatments were strongly predictive of subsequent shock treatment. And the evidence favors aggressive treatment after first shock over conventional therapy. And here's a primary endpoint, intention to treat graph from the trial itself, showing a difference between the primary endpoint of heart failure, hospitalization, and all-cause mortality over 2 years. And that's all. I just wanted to give a nice rapid fire of some of the more interesting cases that I was able to see at the conference. And obviously, this is just the tip of the iceberg. So I'm sure that next week we'll see a lot more, and there's going to be sub-studies, editorials, and reviews that are yet to be seen. Thank you again for the opportunity for me to speak to you all this evening. Thank you.
Thank you very much, Rohan. So you had a very rapid fire, all rounds of different types of topics that were covered. But tell me, what did you find about, I was intrigued, how did that coffee study, I mean, so you're finding a protective effect in patients with previous heart disease, versus you are seeing a U-shaped effect with those who do not have a heart. I couldn't follow that. What was the finding exactly suggesting? So
patients who, this was a retrospective study with the UK Biobank. So when they were looking at patients without coronary vascular disease, they saw a cardioprotective, they saw cardioprotection with 2 to 3 cups of coffee daily. So lower risk of CVD, lower risk of mortality. This U-shaped relationship is when you have a baseline risk of new arrhythmias, but then when you drink the 2 to 3 cups, you have the decrease in your risk. But then when you start drinking more than that, maybe 4, 5, 6 cups of coffee per day, then you start seeing increased risk of palpitations, AFib, flutter, and so on. So there is a cardioprotection within a limit of cups of coffee per day.
Well, I'm going to probably regress to my original thought of excess of anything is bad, right? So there's always a moderate effect, moderation effect. And as much as we want to believe the sodium study, which was very surprising and got a lot of attention, I think there is a little bit more evidence that will be needed before really can translate some of this observations into clinical evidence. So I think this is interesting. I would say retrospective data sets always have a caveat of biases associated. So those are required to be taken with a grain of salt.
100%.
And the other study, which with regards to the VT, but that one is probably more engaging in terms of, I think there is clearly a little bit more maturity in the direction of using ablation for aggressive strategies for VT prevention. But again, this is an area that is going to require a lot of expertise, because VT ablation is not something that you can offer anywhere. So more and more centers and expertise will be required for such kind of evidence to really be able to translate into clinical practice. So we'll wait for that. Dr. Casores has a question. What was the effect of age and coffee consumptions? We previously showed a benefit in elderly.
I'll have to look that up, because I think that there was a little bit more protection in the elderly. I think they did show that again. I'll have to, I think that's something that needs to be reviewed. But I think it was sort of middle-aged, and then to the elderly had the most benefit.
Great. Well, I think those were the rapid fire presentations. We have a part 2 continuing next week. And after that, we'll again resume back to our traditional grand rounds. but look forward to the part 2. And thank you, everyone. And thank you all for your presentations.
Thank you.
Good night. Bye-bye.